depth, but, you guys have me for about an hour and a half before I skip my tip. So, we're gonna run through the arteries, we're gonna go run through the innervations again. Feel free to take pictures of the slide. I won't send them out, but you can take pictures of them. So we'll go through that, and then we're gonna go through those clinical pearls again, just so you can see a picture of them, and then the radiology portion. Was that helpful for you for last time?
Yeah.
Okay, so we'll go over those, some of the ones that I think are probably important on there. So again, if I fly through it, don't try to draw it, just take a picture at the end of your phone or whatever. All right, so this is just, in review, is the arterial map. So remember your common iliac, anything that's common is gonna split. So the common iliac is gonna split into the internal and the external iliac. The two branches of the internal iliac that you need to know for this unit here are gonna be the superior and the inferior gluteal. The common iliac then goes into the external iliac. This is the one that's important as far as branches for this unit. We'll come back to the internal iliac on your last unit. So the external iliac goes over the inguinal ligament. Same road, just change its name once you go underneath the inguinal ligament. Okay, so then it becomes the femoral artery. And the femoral artery is going to give off a branch called the deep femoral. And remember, that's going to provide blood supply to the femoral neck, which is important. So we have the lateral circumflex femoral and the medial circumflex femoral, and that's going to come back in one of your clinical pearls. Remember, why do we have a circumflex artery? Collateral blood flow, right? So if you have damage on one side, the blood reroutes and goes to the other side. It's just collateral blood flow. We're going to see that when we get to your next unit called the circle of Willis that's in the brain, and you'll see that too. So, coming off the deep femoral, you have the perforating branches. Remember that the femur has a ton of blood supply to it. So if you fracture your femur, there's a chance that you could hemorrhage out. Okay, that's why we always want to pull traction and get that femur back together. The femoral artery goes through the adductor hiatus and just changes road names again. It becomes the popliteal artery, and that dives backwards posterior leg. Then it goes into the popliteal fossa. The popliteal artery, because popliteal is around the knee, gives off something called the genicular anastomosis. And genicular just means knee, right? So it's a bunch of anastomosis or collateral circulation that goes to the knee. Once we come out of the popliteal fossa, we're going to branch again. We're going to branch into the posterior tibial, which will give off the fibular branch. And now we're in the posterior leg. Then you have the anterior tibial. So now we're going down the front of the leg to the top of the foot. So the anterior tibial will go down and will go underneath the inferior extensor retinaculum, which is that fiber structure that kind of tacks everything down. And then we're heading towards the dorsal foot. So off of the posterior tibial, we have two branches. We have the medial plantar, and now we're going to the plantar, the bottom side of the foot. So we're going down the posterior leg to the bottom side of the foot. So the medial plantar and the lateral plantar. Remember, the lateral plantar is going to dive really deep, down under the deep plantar arch. And then it becomes the deep plantar. And that's the one, remember I told you, was my nemesis, where it comes from the bottom of the foot to the top of the foot. So the deep plantar artery attaches the bottom circulation of the foot to the top of the circulation of the foot. So between the first and second metatarsals, if you see something pinned coming up from under there, that's the deep plantar artery. Okay, wink, wink, nudge, nudge, you may see that. Then this connects to the dorsalis pedis. Remember I told you that was the arterial pulse that you can feel on the top of the foot? So the two, when you're charting for anybody's lower extremity injuries, what's the two arterial pulses that we document that we felt? Dorsalis pedis and posterior tibial. Exactly. Yep. Okay. So now we're coming to the top of the foot. You have the lateral tarsal branch, which goes to the lateral top side of the foot, and then that combines with the arcuate, and the arcuate is just an arch, and that comes over the top of the foot. And then off the arcuate comes the dorsal metatarsals, which run down the kind of the webbed part, the long part of the foot. And then you have your dorsal digitals. And now this is completed, you can take a picture. All done. Worse or better than the upper extremity? Better? Yes. They're all equal.
Wait, is that like a dress?
Oh, okay. This is going to be the lumbar plexus, and this is just a picture. I'll tell you when the slides are done. So this is just a kind of an orientation of what we're looking at. So this is a picture of a cadaver. We're looking at the lumbar plexus. That psoas major muscle is really important. Remember, the genitofemoral comes out, pierces that, and then lays on top of it. So that's the general femoral nerve that comes out and has that Y at the bottom of that. And then we remember, interested in getting lunch on Friday. That's our role in mind for that one. This starts with the subcostal nerve, which is not technically part of the plexus. But, so subcostal nerve comes down. Then your next branch is going to be the iliohypogastric. And you have the ilioinguinal nerve, that's all, it should be attached to that yellow thing. So remember the iliohypogastric and the ilioinguinal, they share different sensories, but then they share the same motor. You guys remember that from last? Okay. Then we have the lateral cutaneous nerve of the thigh. What does it do? Provide sensation to the lateral side of the thigh. Okay. Then we have the femoral nerve, and then finally we have the obturator. What's the little nerve that only 9% of people have? Yep.
That was gonna break that, or we're gonna see that in the elfish?
That's gonna be more, I think you guys just did this in lecture, right? Yeah, I don't think we dissected it, we're not dissecting this out. So this is just something to know FYI for lecture. But this, so your last unit, it will be retested. So I think for lecture, just know that. All right, here's our lumbar plexus drawn out. And again, if he talks about it in lecture, it's fair to be equivocal. Okay, so interested in getting lunch on Fridays. We have our T12, which comes out to our subcostal. Anything that's in red is going to be motor. Anything that's blue is going to be sensory. Okay, so motor to the internal and external oblique, the transversus and rectus abdominis, and the pyramidalis. There's our iliohypogastric, so that's going to be sensory to our pubic and gluteal region. Motor to our internal oblique and transversus abdominis. What's the next one down? Good, yep. And see how they they share that motor, but they have different sensories. So sensory to medial thigh, the scrotum, and the labia. Then you have L1 and L2. They form the genitofemoral branch, which comes down, pierces the psoas major, and then forms that Y. That's going to be sensory to the femoral triangle. And then that provides us the cremaster reflex. What's the cremaster reflex? Stroke the inner thigh and the scrotum lifts up. Very fun part to it, yes. I told my husband about that. He came home when I was in anatomy, and I was like, drop your pants. He was like, yes! I already have done. Put him back on. He's like, oh, no. Yeah, so fun to try out. All right, L1, L2, L3, they form our lateral femoral cutaneous, which again is sensory to the lateral side of the thigh. L3, L4 is going to be that little pesky accessory obturator. 9% of us have it. And that's going to supply the pectineus, motor of the pectineus. Where do we get motor of the pectineus if we don't get it from this one? Remember, you got it exactly. Yeah. There's our obturator. Remember, that's going to be our adductor thigh compartment. That's going to help with adduction. That's L2 to L4. Sensory to the medial thigh, and then all of your thigh adductors and your hip and your knee joint. L2 to L4 is going to be your femoral. That's going to be sensory to the anterior medial thigh and leg. And then everything that's going to be your anterior thigh. We're going to do a whole slide on just innervation, so that's coming up. So pectineus, anterior thigh, hip, and knee joint. And then finally, we have the lumbosacral muscle. That was all done. Go ahead.
Justin, do you mind Justin?
Steven, we talked.
You guys know how most boring pictures on your phone. Yeah. I have like weird bloody fingers and chainsaws. I look like a serial killer. You guys look. Here's the sacral plexus. Okay. So this one goes from L4 to S4. This one is looks kind of spiderwebby. So superior gluteal nerve L4 to S1. This is going to be gluteus medius and gluteus minimus. Remember I talked about the two pairs of these? So inferior gluteal nerve is L5 to S2, and that's going to be gluteus maximus. And then we skip down to repeating our pairs here. So we have the nerve to quadratus femoris and inferior gemellus, that's L4 to S1. Same thing as the superior gluteal nerve. And then we have our nerve to obturator internus and superior gemellus, and remember that's the same as the inferior gluteal nerve. We have our tibial, which is going to be L4 to S3. What nerve fibers does that travel with? Common peroneal, and what do they make up? You got it, yeah. So they make up that big old sciatic nerve. What's the little itty bitty nerve that travels with that? Posterior femoral cutaneous, good. Then we have, and I'm going to talk about these together, we have the pudendal nerve. And that's going to give off branches to anal and urethral sphincter, pelvic diaphragm, some of the pelvic muscles that we'll talk about. This is going to be more of the next unit. Then you have inferior rectal and peroneal branches. And then I'm going to talk about the next one with it. Okay. So remember we talked about S2 through 4 keeps pee-poo and penis off the floor, okay, because it controls your urethral and your anal sphincter. It also controls muscles for erection. So we have the parasympathetic, remember P for pelvic splanchnic, P for parasympathetic. Is that fight or flight or rest and repose? Rest and repose, exactly, yep. And sacral splanchnic, S for S, is sympathetic fibers. Okay, so you're being chased by a puma, sacral splanchnic is taking over. If you are resting and reposing after being chased by the puma, that's gonna be your parasympathetic or pelvic splanchnic. And then finally, our nerves are levator and coccygeus, and you can take a picture of that, that was done. Easy peasy, right? So colorful. You tell them PowerPoint, so you can start. Well, you're so nerdy.
Even you're okay. Honestly, it's amazing.
You love it? I love the PowerPoint, it's so fun. Okay. All right, so this is gonna be a summary slide. So y'all haven't seen this one in the lab yet, but wait till it's done, and then you guys take a picture. So this is just talking about, and again, we talked about this for our upper extremity, everything back here is radial, and we have everything here in median, except for a couple things, so same thing here. So femoral is gonna be your anterior medius sensory, all the muscles that flex your hip and extend your knee. Then we have the lateral femoral cutaneous, and that's gonna be lateral thigh sensory, you guys already knew that. And you have your common fibular, which comes around the back. The common fibular only supplies one part of a muscle. That is it. So does that sound like a good exam question? Yeah, it sounds good to me. So the biceps femoris, it's the short head, is innervated by the common fibular. That's the only thing that the common fibular innervates. It also provides some sensation to the posterior lateral leg. So that common fibular comes back, goes to the anterior interosseous membrane. Then we have the superficial fibular, which remember controls the lateral compartment of the leg, which is foot eversion. Then we have the deep fibular, which comes out to the front. So that's going to control dorsiflexion. How do you remember dorsi versus plantar flexion? Do you remember that? If you were a dolphin, your dorsal fin would be on your back. Your toe points to that. I used to be a dolphin trainer. I did actually. I'm the only dolphin trainer in PA that's out there. Yeah. So anyways, that's where your dorsal fin lives, is backwards. And remember, plantar, you're planting your foot down, and that's how you remember that. So dorsiflexion, foot inversion, so your foot is coming in, and then extending your toes, and that's all going to be deep fibular. Then we have the saphenous nerve that comes down, and that's going to be anterior medial leg sensory only, no motor. Then we have the obturator compartment, the adductor compartment. When those contract, it brings the leg towards the body. So that's going to be medial thigh sensory and then thigh adduction. So that's everything on the front of the leg. Then we have the posterior leg. So you have the superior gluteal branch, and that's going to be the muscles that adduct immediately rotate the thigh. On the next slide, you're going to see all the list of the muscles, so that's coming. Then you have the inferior gluteal nerve, which extends and laterally rotates the thigh. Then you have the posterior cutaneous nerve of the thigh, which is the posterior sensory to the thigh. Then you have the sciatic, that big old nerve. What's the two fibers for sciatic? What's the two nerves? Tibial and condylar. Good. Yep. So that's going to extend the hip and flex the knee. And you have the sural nerve, which comes down. That's going to be posterior lateral leg sensory. And then the tibial. Remember, the tibial is pretty much everything in the back that innervates it. So that's going to be plantar flexion, inversion, and flexing your toes. The toes, the foot innervations we'll get to on the slide. So that one is all done. Thank you. Let me check. Hold on. Yes, hold on. Go.
So is the sural nerve like a branch of the?
No. Nope, because the tibial branch is off into itself. So that would be a lateral branch kind of coming off the sciatic. Okay, next one. So this is the list of all your muscles. So we're gonna get to it. Don't take a picture yet. We're not there yet. Okay. So this is just in review. So all the muscles that flex your hip, the pectineus, the iliacus, the sartorius, and then extend your knee, which is all of your vastus, and your rectus. That's all going to be femoral. The common fibular, remember, only innervates the short head of the biceps femoris. The superficial fibular inverts the foot, and the muscles that do that are fibularis longus and fibularis brevis. The deep fibular innervates all the muscles that dorsiflex and invert the foot, so that's tibia, atlas anterior, and then fibularis tertius. Remember, peroneal is the same word as fibularis. And then extend the toes, so extensor digitorum longus and extensor hallucis longus. Your obturator is going to do everything that adducts the thigh. So your list of muscles there is going to be adductor longus, adductor brevis, adductor magnus, the adductor gracilis, and the obturator terminus. Superior gluteal, that's gonna be gluteus minimus, gluteus medius, and tensor fascial lati, that's gonna abduct and medially rotate the thigh. You have your inferior gluteal, which is gonna be gluteus maximus, that extends and laterally rotates the thigh. You have your tibial portion of the sciatic, which extends the hip and flexes the knee, and that's gonna be your biceps femoris, except for your short head, which we know is common fibula. Semitendinosus and semimembranosus. Then you have your tibial, which comes back, plantar flexus, inverse foot, and then you have the deep and the superficial parts of that. And those are your muscles innervated by that. So you can take a picture of that one, and it's all done. What do we have? Oh, okay, this is the foot motor innervation. So you have the medial plantar, which runs on the medial bottom side of the foot, and that's going to be your one lat muscle. So one is the first lumbrical. AFF is going to be your abductor hallucis, your flexor hallucis brevis, and your flexor brevis. So you can remember those four muscles. Remember that anything else is innervated by the lateral plantar. So you have the deep branch of the lateral plantar nerve and the lateral plantar nerve. It doesn't matter because they're both lateral plantar. There you go. So that one should be done. Alright, so that's for motor. Now we're going to go to sensory. So the superficial fibula is responsible for most of the dorsal side of the foot. So there's a very lateral, little itty bitty side that's going to be the sural nerve. Medially, before it gets to the foot area, it's going to be the saphenous, and then the deep fibular. The deep fibular is going to innervate between the first and second toes. So if they have numbness in that area, and they have problems with flushing their foot, that's going to be deep fibular. Then on the plantar view, so we're looking at the bottom part of the foot now. Go the lateral plantar, the medial plantar. That's going to be the meat and potatoes, basically the innervation of the foot. You have a small part that's saphenous on the medial side, and then on the lateral side is the sural, and then you have the calcaneal branch of the tibial nerve. That one is completely. What do we have next? Okay, so here's some radiology. Okay, so again, I'm not giving you the answer, but I'm saying I think these structures are important if you look from. You're entitled to. So looking at our hip AP, so anterior to posterior view, this gives us a really good look at the hip joint. So structures that I think are really important are the acetabulum. That would be a really easy one to ask. The femoral head. Do you think they're likely to ask you that in PA school? That's undergrad. That's rookie league. Hi, Dr. Thomas. We were talking about rookie league versus PA school. Whatever. Femoral neck. Why is the femoral neck important? Clinically, we talked about this one. Yeah, that's where the fractures with osteoporosis occur. Yep. Intertrochanteric crest. I think that's PA school caliber. That's a good question to ask. You have your greater troch and your lesser troch. Those are both perfectly reasonable things to do on that view. So again, my goal on this is just to kind of remind you what's really well highlighted on this, because he's going to ask you fair questions. And if you can get a fair shot at it and see what it looks like, then it's likely to be on that view. So when you see this view pop up, start to think about the ones that we reviewed in your head. This is a good AP or anterior posterior or knee. Do you have the lateral epicondyle? So how do you know which one is the lateral from the medial? If you look for the fibula, exactly, because the fibula is going to be on the lateral side. Yep. So has the fibula tells you on the medial or lateral side? You have the intercondylar notch, the intercondylar eminence. Both of those are completely appropriate. Are they going to be like, which one's the tibia and the fibula? That's where you guys are in work. You're paying a lot of money to not be in work. It's worth it. It's worth it. Okay. This is a lateral view. So now we can see the patella here. So you have the tibial plateau, which is the top part of the tibia. The tibial tuberosity, what disease do we talk about the tibial tuberosity in? Osteoschlatter, one of my favorite words to say, yes. And then the adductor tubercle, all really good things. The sunrise view, what we're doing when we're doing the sunrise view is we're having the patient bend their knee and then we're looking directly down into the groove of where the patella meets the femur. So this is called a sunrise view because it looks like the sun is coming up from the landscape. It's very lovely. Yeah. Go ahead. Yeah, well, yeah, but I mean, you can kind of see that the patella is kind of oriented a little bit more medially. What's the muscle that pulls that patella into the medial groove? The vastus medialis. Remember the fibers run this way instead of this way, and it pulls that patella medially, so it runs a little bit more medially. I don't think they'd ask you that. No. This is just an FYI. When we talk about, you know, X-ray versus CT versus MRI, why would we order a CT? What's a CT better than an MRI for? Bone. Bony fragments. CT is better at orienting surgeons and figuring out where the positions of all the bony fragments are, whereas MRI is much better at soft tissues. How much do CTs cost, ish? Hundreds, right? How much do MRIs cost? Thousands, right. CTs take about 3 minutes, MRIs take about 30 minutes. So there's a difference in why you would order them as a PA. You know, MRI is like, well, why wouldn't just everybody get an MRI? That seems like it's a better test, so why would you get that? You don't need it. You're looking at bony fragments, the MRI is actually less good, less better, at orienting in a 3D direction than a CT is. This is our ankle view, so our medial versus our lateral malleolus, and then you have your tibio-talar joint there. We have a lateral of our ankle, so we have the calcaneus, the cuboid, the base of the fifth metatarsal. That's really important because there's a common fracture that occurs there. Your navicular, those are pretty all easy to see on that view. Here's just an example. You're not going to be tested on this, but this is just like when you become a PA. You don't have to take a picture of it. This is just like for your own fun knowledge. So bimalleolar fracture, ouch. That's what happens when you wear high heel shoes in downtown Charleston. That's literally, we saw a ton of those. So that's a bimalleolar fracture. So you can see the fracture here, right there, and right there. So it's a fracture of both. That requires surgery. And then tib-fib fracture. We talked about tib-fib fractures. What we talked about those for? Compartment syndrome. Yep. So it's an itty-bitty compartment that houses the tibia and the fibula, and so you're more likely to get compartment syndrome. So that's just an FYI. Here's your foot AP, so looking down onto the foot. What do I think are good ones out of there? Your cuneiforms are probably testable. Your cuboid is probably the one I would pick. Your cuboid or your navicular is probably the one I would pick if I was testing. Because again, those aren't rookie league, but they're easily to tell them. Again, this is a foot lateral, so you got your calcaneum, your sinus tarsi, your navicular, and then your sesamoid bones. Everybody has little itty bitty sesamoid bones. You have them in your feet and in your hands. You have one in your knee.
Sorry, can you go back to real quick?
Yeah. Have a minute.
Thank you.
Good? Yeah. Okay. This one. Okay, so let's do some clinical pearls. These are the things that I was kind of pimping you guys on. When I say pimping, you all know what that means. Okay. That means I'm like asking you questions on things. Like you're gonna get pimped when you go on rotations. They're gonna be like asking you questions on medical things. I'm not like putting you on a tree. Like that pretty lady said pimping. Yeah, okay. So clinical pearls. So these, when I say clinical pearls, these are all like highly testable material. You guys saw some of your clinical pearls in your last test. Again, these are things that I think are relevant because they're clinically relevant to you. And again, you're in PA school, you're not just memorizing anatomy, you're gonna be using this to treat patients. So, the pin structures, did you guys talk about those? Pin structures? So PIN structures, medial to lateral, that's coming out under the piriformis muscle. That's the pudendal nerve, the internal pudendal artery, and then the nerve to obturator internus and superior gemellus. So PIN are the structures medial to lateral that are coming out underneath the piriformis muscle. Which two muscles have the same nerve? Let's see how much you guys remember. Nerve to what? Quadratus femoris and good. And what's the other one? So nerve to obturator internus and superior gemellus, and then your quadratus femoris and inferior gemellus. I just say that, I was superior gemellus, and then quadratus femoris and inferior gemellus. The nice thing is anatomy named them for what they were going to, which is not always the case, so that this one's kind of helpful. Femoral neck fractures injures this artery and causes avascular necrosis of the femoral head. Let's test yourselves here. What is it? Very good. The medial circumflex femoral artery. And you can see how that one encircles the head. And then when you cut up the blood supply to the head of the femur, then you get avascular necrosis, which just means death because of no blood supply. Most powerful extensor of the hip in the innervation, this muscle is best for walking upstairs and jumping. Gluteus maximus, and it's the inferior gluteal nerve. Yep. Scissor gait is caused by the overactivity of which nerve? Obturator, yep. So as the patient comes over, their leg is adducting in front of them. So it looks kind of like a scissor as they're walking because the adductor compartment is overactive, and we know that the adductor compartment is innervated by the obturator nerve. The overactivity of the obturator nerve. It's just cerebral palsy is one. You can get spasticity with that. It's probably the most common one. But in itself, it's just superficial and deep femoral arteries split over this muscle. Adductor. That sounds like a good exam question. Make sure you guys are reading your syllabus notes too for your lecture notes for class, because he's picking a lot of your test questions out of there. And if you if you don't read that stuff, I mean, I try to pull it a lot in your clinical pearls, but that's an important resource to be reading. All of your hamstring muscles originate on which bony feature? Very good, the ischial tuberosity. So if you have a fracture to the ischial tuberosity, then none of your hamstring muscles are going to work properly. Location of IM buttock injections. Which quadrant? Upper lateral. Okay, upper lateral. Because that big old sciatic nerve is going right through the center, and that's the last thing you want to hit on a patient. I'm sure they'd be very unhappy with you. Yep. A fractured distal femur can damage what artery? Because the pull of the muscles will pull that bone back into where? What's going to be the artery? The popliteal artery. So the popliteal artery runs back. If you have a fractured distal femur, the muscles are going to pull all of that fracture back into the popliteal space, and it can damage the popliteal artery. This gait is due to the injured gluteus medius and minimus. What's it called? Yep. And so the pelvis will drop because you have an abnormal gluteus medius and gluteus minimus. What's the largest nerve in the body? Very good. What other nerve travels with it? You guys are so genius. What is the unhappy triad if a patient takes a lateral blow to a knee in a sports injury? What are the three structures that are going to be damaged? MCL and medial meniscus. Very good. Yep. So the medial meniscus is attached to the MCL. And so when it pulls the MCL, it pulls the medial meniscus with it. That's your ACL. You know, I don't know. I feel like that would be really unlucky. Not only is it unhappy trying to be unlucky trying to be from a hockey. I don't see. Good call. I don't know. The number one knee ligament injury, the patient will experience a pop. They'll have immediate swelling in their knee, and they'll be unable to weight bear. That's not true. Yeah, there is a test called the anterior drawer test. Did you guys talk about these tests? Yeah. So the anterior drawer test is when you pull somebody's leg forward because their ACL is out, it will anteriorly translocate. PCL will test the posterior cruciate ligament. Number one ankle injury, we talked about this today. The patient will plantar flex and then invert their foot. What's the ligament that's going to be damaged? Your brains are so full. That's gonna be the ATF ligament. The anterior talofibular, because when you roll your ankle, that's gonna be the ligament. And sometimes a ligament sprain, sometimes like a sprain is actually worse than breaking the bone, because the body doesn't get excited about healing it. And it takes forever, and it has a poor blood supply. Whereas bones have a great blood supply, and the body gets really excited, there's a fracture that can go in and heal that. These things take forever to heal. You're in a walker boot for like 6 months. Number one place for compartment syndrome. Tell me the P's for compartment syndrome. We talked about this today. Pain, purple or pallor, good. Paralysis, pulselessness, and poikilothermia. Very good. I know, it's in my yeah. They were for cold. Poikilotherms are your sweet little cold-blooded animals. We love them too. So this is going to be for a tib-fib fracture. It's going to be the anterior leg. And that's a fasciotomy. That's what they do. They go in and theirs is usually more of an S-shaped incision because they get multiple compartments and they do an S-shaped incision, but that is releasing the pressure out the compartments. They're saving this guy's leg. The posterior tibial pulse is palpated between where? Medial malleolus and the calcaneal tendon. Pain over tibial tuberosity in a teenager. What's the disease called? Flutter. Really good. Yeah. And that's the X-ray there where you can see that tibial tubercle is being pulled up because it's a growth plate. And so this is called a traction apophysitis, where that patellar tendon pulls against the growth plate and it actually pulls it off of the leg. You have that? You have that? You did? Well, no. You and your eyes get slaughtered.
Is there a way to stop that? Like, if you take an
Stop
X-ray,
jumping.
notice that?
No, truly, stop jumping.
Oh.
Yeah, it's treatment. Stop doing all these crazy gymnastics that the kids do these days. It's like crazy. Everybody's getting concussions from football and all this crazy stuff. I see like fractures all the time and like gymnasts and stuff like that. Don't be crazy. That's the answer. Okay, so this is our summary for innervations. We've already done a whole slide on this. So what's the anterior thigh innervation? What's the nerve? Femoral. Good. Posterior thigh innervation? Tibial. Good. Except for the short head of the biceps, which is going to be condylar. Good. Posterior leg innervation. Tibial. Very good. Anterior leg innervation. Defibular. Good. And the lateral leg innervation is the superficial fibular. Very good. Let's go this.
Did you know that other one?
This one? You need the one before that? No? Okay. Foot innervation. We talked about this one. I'll just skip this one. So all of them are lateral plantar except for one lap. Be it the superficial or deep branch, it doesn't matter. They're all lateral plantar. So everything else is lateral plantar except for one lap, which is going to be medial plantar. Just like your lobe muscles in your hand. Pulse of the artery in the foot. What's the one you can feel on the top of the foot? Dorsalis pedis. Yep. Remember when we document any lower extremity injuries, we document the dorsalis pedis and the posterior tibial. Yeah. Good. There's your dorsalis. And that was really superficial. You can easily feel that one. Toe abduction muscles and innervation is going to be the dorsal interossei, and that's going to be the lateral plantar nerve. Shocker to the foot is lateral plantar nerve, which is foot drop muscle in the injured nerve. You guys remember what that one was? Anterior tibial, good. Yep, tibialis anterior and the deep fibular nerve. So the patient will not be able to dorsiflex their foot, so they come in with a foot drop. So they're going to kind of drag their foot along the ground. Swollen calf, no plantar flexion. Which tendon is going to be ruptured? The big old calcaneal, yep. So you can see a big difference between that left foot and that right foot. So you can see the nice slender contour of the calcaneal tendon in the right foot and then nothing in the left. Yep. What type of medication, you guys don't need to know this yet, but what type is just fun facts? What type of medication could cause somebody to get a calcaneal rupture? Fluoroquinolones and steroids. So antibiotics are not just Tic Tacs, which all your patients will tell you they're Tic Tacs, they're not Tic Tacs. They are side effects. So, the most common patient that we see this in is COPD patients, because they get a lot of blood-appointed steroids, because they get COPD and bronchitis. Sustentaculum that's that shelf-like feature. Fracture is gonna affect which muscle? Close enough, but our as longest. So it comes underneath that sustentaculum and it gets tucked underneath there, and so when you have a fracture underneath there, you're gonna have problems. No dorsiflexion, no inversion, and numb between the first and second toe. Which nerve was injured? Got it, the vestibular nerve, yep. Because remember, it supplies sensation in between the first and second toe. It's responsible for all of your dorsiflexion and your foot inversion. Okay. Numbness on top of the foot, what's your dermatome? Okay. That is all the knowledge I have for you today. 5:47.